Okay, we have a good bit of folks, and I imagine we'll have some others trickle in, but I will just say very quickly, I'm Tanya Lauder. I'm the Director of Finance for CFHA, and I have the privilege of working with Corey Knight, collaborating on the community conversations, and we are thrilled to have everyone here today. I'm going to turn it over to Corey, who will then introduce your speakers and turn it over.
Hi, good morning, good afternoon. Hello to everyone on the call today. My name is Corey Knight. I am one of our community conversation facilitators, in addition to Tanya, and I'm a health service psychology intern at Community Health of Central Washington. And I want to welcome you all to our monthly community conversation. We have a wonderful, wonderful topic today. I'm excited to hear more about it, and I hope all of you are as well. As part of our community conversations, we definitely encourage active engagement. My sense of things is we will be keeping an eye on the chat for questions, and then we will make some time at the end to address some of the questions. And I'll work to keep on top of that as well. So without further ado, I'd love to turn it over to you, Dr. Coons, just to start to introduce everybody and get this rolling.
Well, thanks so much. I'm going to be sharing my screen, and I'm going to hopefully share my screen. We are having a little technical issue, so I'm sorry, but you're going to see my slides like that. I don't dare touch anything else, since when we got logged on, I touched something and it shut down my entire computer. Welcome, everyone. We are thrilled to have a community conversation today focusing on integrating behavioral health care in outpatient obstetrical settings and talk about strategies to improve maternal health and well-being. I'm particularly thrilled, while I admit that I'm sad that we didn't hold this meeting in January when I was stuck in Philadelphia for 2 days because of mechanical problems, that we actually now are having this community conversation during National Women's Health Week. It couldn't be more relevant. To quote the March of Dimes, maternal mental health conditions are one of the most common complications during pregnancy and the postpartum period. These conditions impact over 800,000 families each year in the United States, and the pandemic has exacerbated this crisis nearly 3 to 4 times over. I might add that health disparities in the United States across marginalized populations have further exacerbated this crisis. It's my pleasure to serve as your host for this community conversation. We couldn't thank CFHA more for your support and recognition that we have colleagues all over the country in a variety of integrated settings, and those who would like to develop integrated services in obstetric and GYN settings, as well as other healthcare, women's health practices, and are so interested in this topic. I look forward to introducing Dr. Ashby and Dr. Thomas shortly. From my perspective, from consumer groups' perspective, from health systems' perspective, and especially from patients and their families, we have an imperative to integrate mental health services in obstetrical settings. While it's way beyond our conversation today to go through all of these reasons, I'm going to highlight a few. First and foremost, to improve access to the continuum of mental health care for persons at risk and for those with perinatal mood disorders, anxiety, bipolar and psychotic disorders, substance use disorders, and individuals with a history and present trauma. We have a true opportunity to screen, evaluate, and prevent, please note that word, psychosocial issues and challenges, mental health and substance abuse conditions before, during, and postpartum. We can really be far more effective at reducing rates of PMADs and suicide among birthing parents. We can improve both physical and psychological well-being of persons who are planning a pregnancy, become pregnant, or are postpartum. We're in a position when we integrate care to provide early and effective initial diagnostic workup and prevent both an initial presentation and the exacerbation of mental health disorders through early screening and intervention. We know from good data we can improve pregnancy outcomes, and actually we can improve physical, emotional, and developmental outcomes in infants and in children by minimizing risk for maternal mental health conditions. But that's not all. I think that's only part of the conversation. When we integrate the continuum of behavioral health services and other services in obstetrical settings, we can also address other mental health and psychosocial challenges of persons who have experienced pregnancy complications and loss, neonatal complications and loss, infertility, difficulty accessing pregnancy terminations, individuals with limited or no practical or emotional support, all too many patients with past and current trauma, patients who have experienced birth, gender, racial, and other types of trauma, and so many other reasons why we have an imperative to integrate our services in outpatient and frankly inpatient obstetrical settings as well. In my mind, this is all about how do we promote the thriving and wellness of our patients and their families who are experiencing, who we see in obstetrical settings and are dealing with any type of OB related issue. I think the benefits, we need to preach to the choir of integrating mental health care in obstetrical settings are clear, but I included this slide because some of you may want to take the PDF of our slides and use them as the basis for a business plan in your settings. So we're not going to go through all these. One of the most important I want to note, though, besides improving access to care, is truly reducing disparities to access to all too many populations who find it overwhelmingly difficult to access high quality mental health services in this day and age. In addition, we're far more effective at addressing social determinants of health and mental health through integrated care. The rest of this list is all too familiar to all of you. I've included a slide for many of you on really good stats and resources on mental health that many of you may want to use if you're needing to develop a business plan. And I haven't asked Dr. Thomas or Dr. Ashby, but all of us are no doubt willing to serve as consultants. This is something I do about twice a month to practices and health settings across the country, and we would be more than happy to provide expertise. I did want to highlight a brand new resource that's just been published in March. We had the pleasure of co-editing a major special volume in clinical obstetrics and gynecology on integrating mental health care in both obstetrical and GYN practice. And I've listed the 10 chapters, and you can see that that 6 of the chapters all have to do with the integration of mental health services in both inpatient and ambulatory obstetrical settings in all kinds of different OB practices throughout the country. So we welcome you to use this as a resource. We also, if you didn't hear at the beginning, invite you to introduce yourself in the chat and let us know what your role is and what kind of setting and where in the country you are. And you'll be invited to ask questions throughout this. Without further ado, I'm going to introduce Dr. Bethany Ashby, and then I'll introduce Dr. Thomas before she speaks. I'm going to bring my slides down so Dr. Ashby can put hers up. And I'm sorry about the tech issues today. We invite you to use the chat or Q&A to ask questions. Dr. Ashby and Dr. Thomas are each going to speak for 15 minutes max. And then we're going to just have a robust conversation about anything that's important on your mind, challenges, strategies to integrate, business questions, funding, what works, what doesn't work, lessons learned. All questions are good questions. So with that as a very superficial background introduction to a vital topic, it's my pleasure to introduce my dear colleague and esteemed colleague, Dr. Bethany Ashby, who is both a clinical psychologist and associate professor in the Department of Psychiatry and OBGYN at the University of Colorado School of Medicine. She has served for a long time and continues in this role as the director of the Promise Clinic and the Colorado Adolescent Maternity Program, both at the University of Colorado Hospital in Aurora, Colorado, just outside of Denver. Dr. Ashby also serves as the director of integrated behavioral health in the Young Mothers and Family Clinic at Children's Hospital of Colorado. She has expertise in perinatal mental health and deep experience in the development, implementation, and evaluation of integrated perinatal behavioral health programs. Dr. Ashby, welcome. Thank you for sharing your expertise, and you're going to be sharing with us the Promise Clinic and the Colorado Adolescent Maternity Program, Integrated Obstetrical Care for High-Risk Populations. Dr. Ashby, feel free to share your slides, and welcome.
Thanks so much. I'm really excited to be here today and to talk with you all about this really important topic. Let me share my screen. Here we go. Okay. There we go. Everybody can see? The slide's great. Okay. So as Helen said, I'm a clinical psychologist and really going to be talking about integrated care in a couple different settings and different with different populations and how we've done that at the University of Colorado. So I'm going to start first with the Promise Clinic, which is a large integrated behavioral health program offered at our main campus. So it's the University of Colorado Hospital, or UC Health is what it's now called. And at our main campus, we have 5 obstetric and midwifery practices that deliver about 3,000 to 4,000 patients per year. I also want to say before I start, I may erroneously say mothers and moms, and I mean patients and pregnant people. And so when I slip up, please know that I am working on that, and I apologize. So in our model, our integrated behavioral health program is provided as part of routine care. So if you come to our Anschutz campus to get OB care, you are very likely going to see someone from my team. We end up serving about 1/3 of the total patient population. We provide a mix of in-person and telehealth services. So we have clinicians on site every day, but then our scheduled appointments are offered over telehealth. We're sort of forced to do that during the pandemic, and it's worked really well. And when we've done patient satisfaction, we're doing a patient satisfaction survey, and 0% of patients say they want all services in person. So, which was kind of interesting for us. We were expecting people to say we want to go back, but we've continued doing our scheduled appointments over telehealth. And we do individual mom, baby, couple, or group therapy, and then medication evaluation and management. So I have this history slide, not because I think the history of Promise is really important to you all, but because I think it highlights that our work is important regardless of the form that it comes in. So we started in 2010 with a psychiatrist and an OB who volunteered their time, to almost 15 years later, being integrated 5 days a week with multiple providers, clinicians and psychiatrists. And I think sometimes when we go to implement programs, we think this is the way we want it, and we're not there yet. And it feels like it's not good enough, and it's good enough. Whatever you're doing is good enough and really important, and it matters. There we go. So from one psychiatrist and one OB to our team now, you can see we've really grown really exponentially. And it's been exciting and amazing to be able to do this work in a way that we feel like is really meeting the needs of our providers and patient population. So our goals for patient care, I think, really frame the way that we've implemented the work and the way we think about the work. So kind of our number one goal is to provide care to patients who would otherwise struggle to access care. So this means we are thinking about uninsured patients, patients on Medicaid, gender diverse patients, patients who don't speak English. That is really the way that we think about providing care, is making sure those patients get what they need. We are also really considering patients' lived experience. We know patients that are underserved and underrepresented have a lot of negative experiences with our systems of care, particularly our medical system. And so really keeping in mind, what is it like for them to be in our space? And what are we doing to meet their needs versus asking them to change to be a good patient in our medical system? We're thinking both about patients' mental health issues and their desire to parent differently. I have never had a patient, including myself, who says the way I was parented was great and there's nothing I want to change, right? We all have things about, I'd like this to be different. And so we want to hold that in mind. We also are thinking about the right services, the right time, and the right dosage, and that patients decide what right is. So that's not up to our team, it's up to patients, and our job is to adapt to that. So some of our model highlights include that patients can be seen at any point in pregnancy up to 6 months postpartum. We really drew or designed our program based on primary care models so that we are not a specialty practice. So people who are pregnant can see us for a variety of reasons. It doesn't necessarily have to be identified as a pregnancy-related mental health concern. So we see patients with long histories of mental health issues and with really significant psychosocial stressors. Another piece that we like to highlight is the process of patient connection is bidirectional. So ROBs and midwives are chat. We use Epic, they use the Epic chat. They are chatting us all day saying, please come see this patient. They had an elevated EPDS. They're crying during our visit, which is a big referral is a patient is crying. So we see that a lot, but we also, our clinician team is also reviewing charts of all new patients, and we have a list of risk factors. And if a patient has risk factors that we've identified, we're reaching out to their provider and saying, hey, if your patient has this history, we'd love to meet with them today. Our initial appointments are scheduled across provider disciplines. So if you want to see a psychiatrist first as a patient, that's great, that's who you see. We also, our psychiatrists really think about their medication evaluation appointments as really opportunities for patients to talk with an expert about safe medications in pregnancy. So you don't need to want to start medication, you need to want to ask questions about medication or to explore options, and that's when you see our psychiatrist. All of this didn't intentionally happen, but it's been, I think, a really kind of cool thing that's happened in our practice is all of our providers were trained in child and adolescent mental health. So, and are connected to our children's hospital and other parts of their work. So we are really connected with our pediatric practices and really thinking about the continuum of care, both for parents in terms of mental health treatment, but also in terms of primary care for parents and pediatric care for their kiddos as a primary point of our focus. So here are some of the risk factors that we look at when we are doing chart review and reaching out to providers. There's a variety of mental health and medical conditions, also psychosocial stressors, diversity factors that we're looking at. And then I highlighted young maternal age because in just a couple of minutes, I'm going to talk about our Colorado Adolescent Maternity Program, which is designed for adolescent patients. And then just to give you just kind of a brief overview of who we serve and kind of in our outcomes for 2023. So we saw 1,200 patients, which is about a third of the patient population. Not the majority, but a large percentage of our patients are publicly insured. 94% of patients would refer family or friends to us for services. And then one of the things that I think is really important to our medical colleagues, they are really happy that we are treating depression and anxiety, but I think for them, it's particularly meaningful when we can improve birth outcomes. And so in our patient population, regardless of your depression score or your score on ACEs, higher levels of mental health support during pregnancy, so increased dosage, were linked to better birth outcomes, preterm delivery and low birth weight, regardless of your history of depression and childhood maltreatment, which is pretty exciting for us as a team and for our medical colleagues to say, like, this made a difference and it mattered in this long-term outcomes for this family and this baby. So switching directions a little to our Colorado Adolescent Maternity Program, or camp, so that's what you'll hear me refer to it as. I think it's really important to talk about why a teen pregnancy program is needed, because sometimes people feel like, you know, it's reproductive healthcare regardless of age. And from a mental health and developmental perspective, that's not true, right? Because teens have a very different way of thinking about the world, of interacting with people. They bring lots of unique pieces to the way that they think about being a parent as compared to adult patients. So this is just some rationale for why we need a teen pregnancy program. They have higher rates of trauma, higher rates of mental health issues prior to pregnancy. And those mental health issues and childhood trauma issues impact their pregnancy outcomes. They're at higher risk for premature birth and low birth weight babies. They tend to breastfeed shorter periods of time. Their babies have more difficulty with staying on their growth curve. So there's a lot we want to do to support adolescents. We are fortunate in Colorado that abortion access is unrestricted, but in a lot of states that is, and contraception access is unrestricted, but in a lot of states that's not true. And we know that there are going to be more and more adolescent parents in states where those things are heavily restricted. So again, this is the history of camp, which again highlights, we have done all kinds of things in camp. We have been at our university hospital, at our children's hospital, at an FQHC. Now we're back at our university hospital, but regardless, we have been working to provide care for teen patients since the 90s. And so we just sort of go with whatever the powers that be say, this is where you can practice care, OB care for teens. We are going to be there and we're going to do that work. So we serve patients under age 22 through their 6-week postpartum visit. And then once they discharge from us, they're referred to our teen parent program at Children's Hospital. So they and their babies can get care until the birthing parent turns 25. We offer, that's the list of services we offer, and they're really designed for adolescent parents. So the way we talk about shaken baby syndrome and SIDS and contraception is a very different way than we might talk about it with adult patients, because we know adolescents think about these things in different ways. The way they make decisions is different. And so we want to provide a special support for these patients. Our census sort of changes dramatically based on different programs in our community. Sometimes maybe offering more resources, like we had one of our sister hospitals was giving strollers and car seats. So a lot of patients went there. So it sort of depends on grants and other services that we provide. In the past year, we served 125 patients. The majority are publicly insured or uninsured, and it's a very diverse patient population. Sorry. And in terms of our outcomes, once we hired integrated behavioral health clinicians and implemented trauma-informed care, we saw really significant changes in birth outcomes for our patients. They were more likely to come to appointments. They had repeat pregnancy rates of less than half the national average, which is pretty amazing. And one of the things that we were most excited about is the, regardless of race and ethnicity, there were no differences in rates of preterm and low birth weight, which we know women of color have much higher rates of low birth weight and preterm delivery. So this was really exciting for us to see that when we do trauma-informed care and have mental health providers on site, things look different for the life course of this family and this infant. So thanks so much for letting me talk about our programs, and I'm excited to hear what Dr. Thomas has to say.
Thanks so much, Dr. Ashby, and thanks for going ahead and take your slides down. This is truly a robust, impactful program, and we're grateful for your willingness to share what you've learned and where you are with a national audience, and really as a model. And I asked Dr. Ashby to share her experience both for adults and high-risk teens, because it's a model program, and I wanted to do one example in academic medicine of a highly successful integrated programs in ambulatory OB. And now I'm going to turn to Dr. Thomas, and who's coming from more of a community setting. And it's really my honor to introduce Dr. Jennifer Thomas, who is board certified in both family and addiction medicine, and currently serves as medical director of integrated behavioral health at Morris Hospital in Morris, Illinois. Dr. Thomas also recently joined CFHA as the National Medical Co-Director for Integrated Care. And congrats, Dr. Thomas, for both bringing your expertise and your leadership. In her clinical care through Morris Hospital, Dr. Thomas has helped launch a collaborative care model service line for Morris Hospital's OBGYN and primary care departments beginning in 2019, and she continues to support that work for the perinatal population. Dr. Thomas has kindly offered to speak with us on perinatal collaborative care, lessons learned at Morris Hospital. Dr. Thomas, welcome, and thank you for sharing your expertise and your programs.
Thank you, Dr. Coons. It's my pleasure to be here. It's such an honor to speak with all of you. I'll share my screen too, and I'll kind of tell our story of the flavor of integration we do at Morris, if that sounds good to all of you. All right, so let's go from beginning. That look okay to y'all?
Okay. Yes, it can.
Okay. All right, sounds good. Well, hi guys, I'm Jen Thomas, Family Med, Addiction Med, Morris Hospital. So I'm a family practice provider. We're in a community setting in Illinois that's about 2 hours southwest of Chicago. So we're definitely on the collar of suburban Northern Illinois, more in a rural setting. I practice out of Gardner and Braidwood, Illinois, which are smaller towns that feed into the Morris Hospital system. So we're definitely more rural out where I practice. So primary care does a lot of behavioral health in the communities that we serve. So yeah, I'm just going to tell our story about how we got started with collaborative care in our neck of the woods. So our practice of OBGYN providers has 6 physicians, 1 nurse practitioner, and they serve a big geographical swatch of our service area, 5 Illinois counties, 4 office locations, where our payer mix is about 1/3 Medicaid, 2/3 commercial. Our providers have up to 600 deliveries a year, and they also serve a level 2 special care nursery. So our journey into using integrated behavioral health for OBGYN really didn't start intentionally. It was kind of right place, right time. So our system, this was back in 2018, was looking to integrate behavioral health and try collaborative care. And we were fortunate enough to build a collaborative relationship with the University of Washington Ames Center. They were recruiting sites for a perinatal COCM study. And we said, hey, we have pregnant patients and we want to learn COCM. So we joined up with them and got implementation training for Ames Center without the cost associated. So that was kind of the turning point for our CEO to say, okay, try this thing. If it's not going to cost us anything to get implementation training, and we've tried to hire our way out of the psychiatry problem. I know that specifically as a PCP, like we struggled with that all the time. It was, we couldn't just hire psychiatrists. We couldn't just refer everything out. There weren't we didn't have a robust community mental health center. We had like 1 nurse practitioner at our county health department that could prescribe, and then that provider left. So primary care did the bulk of behavioral health in our health system. So we really did have to kind of turn that obstacle into opportunity and look at other models. And we're just very thankful that we found COCM. So yeah, that was back in 2018. We launched in 2019, and our providers at the OB practice haven't looked back since. We had some turnover about 1.5 years ago, and one of our providers at the med staff meeting was like, when are we getting a new care manager? We cannot practice without her. We're not going backwards. This is so essential to our daily DNA of OB care that we're not going backwards. So we thought that was a real turning point for our culture. So how we got started, our OBGYN practice uses universal depression screen. PHQ-9 for everyone that comes in the door. As you know, with COCM, there's also that measurement-based care piece where the PHQ-9 is then used subsequently to monitor symptoms. Our OB providers are coached in how to give a quick elevator pitch to describe the model, team-based care, and then provide that warm handoff or warm connection to our care manager right in the OB office. And then our OBGYN providers serve as the PCP. So, the collaborative care triangle, the top corner is a prescriber. That's our OB doc. And that was a bit of a culture shift. A lot of early comments on we're a surgeon, we're not psychiatrists. Prescribing psych meds is not our jam. It's not something we're comfortable with. So that was really a learning curve for our team. But again, thankfully, with the support of a great perinatal psychiatrist that's very collaborative, very helpful with teaching, and then that care manager helping do that work and monitoring, we really were able to up the game of those OB/GYN providers to get them comfortable with prescribing. So our providers usually prescribe meds for patients in the prenatal period, and they may even hang on to med management for those patients for up to about 12 months after delivery. So how does that look on our patient panel? So if you think of all the OB/GYN patients, a subset of them can do collaborative care. Episode of care might last 6-9 months, again, maybe several months up to a year postpartum. But true to the collaborative care model, we're hoping that at the end of that episode of care, patients are doing better functionally. Their PHQ-9 scores have significantly decreased. Their symptoms are much less burdensome. So they'll be talking to the care manager about a relapse prevention plan, right? How do I know my depression's worse? Well, I have signs like I sleep more, or I'm late to work, or whatever that might look like, in which case they can re-engage in a new episode of care, absolutely. Some of those patients, though, through this process, get identified with more severe mental health conditions, and we might need to refer them on to specialty mental health. So we use this graphic a lot just to kind of help even just our reception staff and clinical staff just really conceptualize, like, what is that collaborative care turnover and throughput look like? So for transitions of care, this is something we've kind of had to learn by doing. Our OBGYN group has a good, strong connection with our primary care providers. If ongoing support is needed, our care manager will reach out to the patient's medical primary care provider and determine if that PCP is comfortable doing the med prescribing as part of the collaborative care team. That happens more frequently with our patients that have more of the serious persistent mental illness in our system. We've got 6 nurse practitioners and myself that did a primary care psychiatry fellowship training out of University of California, Irvine. Great program, year-long. It was really helpful in getting PCPs more comfortable with diagnosing and prescribing psych meds in the primary care setting. So put a big plug in for that for anyone who's like, hey, I'm not going to quit my day job, but I need to know more about psych prescribing. That was a great program. So in reality, what that looks like is then after that 12-month period, sometimes the OB docs say, okay, this person has mood disorder and needs a lamotrigine prescriber. Can you or one of the nurse practitioners take them on as med management? And we kind of piece it together that way. Partnering with pediatrics, our pediatric group also delivers collaborative care. So they're very aware of the model. They're very invested in it helping families function as a whole. So our pediatric providers routinely screen the mothers or the parent of their newborn babies at the 2-week visit with a PHQ-9. So our workflow is that if that mom is identified with an elevated depression score, the pediatrician, we gave the example of Dr. Hill, would message the OB doc, one of them in the chart. Hey, your patient Jackie delivered last week. She's got an elevated PHQ-9 today at her son's 2-week well check. And then the OB provider, might write back, thanks, Dr. Hill. Jackie's coming in for her postpartum check this week. We'll make sure to follow up with her on that score and ask our care manager, Katrina, to reach out to patient to see how she's doing. So we really try to keep that connection between providers, because I think we all know that siloed approach where one provider isn't talking to the other doesn't serve the patient. So really trying to improve that culture of communication amongst our team and our providers. So our implementation, again, we've been doing this since about February of 2019. What was helpful about that, again, huge piece was that we received implementation coaching from the AIMS Center. The study that we were part of, Dr. Amrita Bhatt was the head researcher. It was the MIND-I maternal infant dyad implementation. So they were looking to see, does collaborative care model improve outcomes with usual care implementation or with what they called the longitudinal remote consultation. So that's where the team had extra support of a perinatal psychiatrist remotely. And other things that were helpful for our team is that the cost of the registry was part of the research study. I know that implementation costs, startup costs can be a challenge for a lot of systems new to collaborative care. What else helped our team? We co-launched with Family Medicine Clinic. That's where I worked in Gardner, Illinois. So we had my family medicine office in Gardner, Illinois, and then the OB office in Morris, Illinois, launching at the same time. So again, we didn't necessarily start out to begin with OB, but we did, and it worked great. And now we've got collaborative care at every primary care office, including all our pediatrics offices. So there was a real push. I know part of what kept us successful is our providers saw the value. They really enjoyed having those extra teammates, really found it crucial to have the psychiatrist in the chart helping support. And if we got stuck with, hey, I've already tried 3 meds, I don't know what else to do for this patient, it's just extremely helpful to have that team documenting in the EHR and working with you rather than just saying, here's a referral, here's the phone number, and good luck finding a provider. So we did combined trainings, like our front end and nursing staff. We could pull them together for, okay, this is what collaborative care is. This is how we're going to do PHQ-9s. So that was nice to kind of dually train those 2 groups of people since it was a new pilot for us. Other things we had to figure out, we had to transition away from the EDS. We use PHQ-9 and now in the OBGYN setting. At first there was some like, oh, this is new and we're not sure we want to do this, but in time it was easy to kind of make those transitions and kind of never look back. Another huge piece of our success, I would say, is a really strong psychiatric consultant who's comfortable with the perinatal population. So again, we tried partnering with local Illinois psychiatric providers. We just couldn't find a provider. Again, this was 2018 that was wanting to try this model with us. So we ended up using a telepsychiatrist. So again, we're in Illinois. Our psychiatrist is remote. She works for Array Behavioral Health, Dr. Norell, and she's out in Virginia, but she zooms in with our team, 8 hours a week, does her documentation, messages the care manager, supports our PCPs, and it's worked beautifully and really helps a lot of our PCPs just to learn more. It kind of raises all boats when we have those educational support opportunities. Other lessons learned, I would say we're trying to just be more intentional about the team. I think we still have a bit of culture shift to overcome with having the care manager kind of thought of as the behavioral health person down the hall. So anytime we can reinforce that, nope, they're a member of the team, just like the nurse, just like the doc or the nurse practitioner, that they need to be in those daily huddles. They need to be looking at the patient list, identifying those that might need extra support is a good thing. We had turnover in that care manager role, like I mentioned earlier, about 1.5 years ago. And I think we thought we'd have someone in that role a lot quicker. That chair, that position, it was like nearly a year before we had somebody onboarded and ready to go. So in the meantime, we ended up just kind of asking our other care managers who were stationed at sites not even close to Morris, but did primary care to internal medicine or family medicine collaborative care, if they could keep eyes on some of these patients, because we didn't have a care manager. We still did the med management piece and still the psychiatrist, but I think we kind of, needing in retrospect needed to look back at, hey, we need to have a better plan for monitoring those people on our registry, that if turnover happens, which it will, how are we going to address that? How are we going to make sure that those patients still get the care that they need? But yeah, those were kind of our main big lessons. I think it's been a really fun implementation journey, and really can't say enough about integrated behavioral health as a clinician. Again, I'm family medicine. We did deliveries of OB back in the day. I don't do that currently, but it was like we had our paper pharmacopoeia, and it was, okay, what ABCD class are these meds? What can we prescribe safely? And that's just, we need so much more for our prescribers, especially in rural settings where maybe we don't have all the opportunity to just send to a psychiatrist, let them figure out the psych meds. So again, that team base, I can't speak highly enough of the importance of that. That's all I had, but thank you, Dr. Coons. Thank you, Dr. Ashby. I super enjoyed hearing about your guys' programs. So I'd love to talk to the audience too and do some Q&A.
Well, thanks so much, Dr. Thomas. And I want to say that you have a wonderful model of collaborative care. And I love that both programs.
Helen, sorry, you're really hard to hear. Can you maybe lean?
Can you hear me better now?
A little bit.
Huh. Okay. If you keep having trouble hearing, let me know and I'll turn my volume up. I hope that wasn't an issue when I did the introduction. Good. So we have two very different programs, one in academic medicine, one in community / almost rural Midwest United States. Both programs prioritize access, are working with marginalized communities, have interprofessional staff and providers, have deep communication and collaboration, and have very different approaches and really effective and impressive outcomes, both in terms of maternal well-being and in pregnancy outcomes. And so I want to just note that there is no one size fits all here. And I love what's the best approach at the best time for the right person with the right team. We didn't really talk a whole lot about leveraging system support. We can talk about and finance and evaluation of outcomes. Well, we can do that. What we like to do is now and thank you so much for limiting. I know both of you could have spoken for 2 hours, and if there's interest, we will always deepen this conversation with CFAJ's invitation. We know that some of you would also like to hear more about integration in other areas of women's health, for example, general GYN and women's primary care, women's multi-specialty, and specialty settings. And I think that's a slightly different program, and we are happy to facilitate that conversation as well. But without further ado, the time is yours. All questions are good questions. I believe that Tanya is gonna gonna ask questions, and then Dr. Ashby and Dr. Thomas and I will sort out who should respond or if we all should. So I'm gonna turn this over to the CFHA leadership.
Yeah, and I'll jump in and start with some of that as well. So thank you all for just such wonderful descriptions of the work you've been doing and just some of the important impacts you've been having in different parts of the US here. So the first question I have is, Jennifer, what qualifications do your BHCMs carry? Are they licensed clinicians? Are their visits/services billable to insurance?
Okay. Yeah, so we are using collaborative care models, so we're billing the COCM code. So definitely recommend looking at your state requirements and payer requirements of what credentials the BHCM behavioral health care manager would need. Now, as COCM, it's billed through me as a PCP. So the model, and CMS would back that up, is that technically you don't need a licensed mental health provider. Some sites use RNs with extra training in motivational interviewing or behavioral activation. But again, I think it doesn't have to be one size fits all. My setting, I have licensed providers because that's what my hospital system wanted. They said we can put an LCPC or an LCSW in that chair, and that's great. And that's what we've done. But technically, we could have a master's level person filling in that role that's maybe on track to train to get licensed. So I think just being very mindful of what those billing requirements are to kind of start thinking through who can you recruit, who can fill that role. And then, yeah, kind of backpedaling on, okay, which codes are you going to use to bill? Does that help? I hope that was, yeah.
Okay. I also have on here, what CPT codes do you typically bill for these sessions? People we've spoken to say that they've gotten pushback from insurance.
Dr. Ashby, you want to take that for to
Sure.
start? Mm-hmm.
Yeah, we bill H&B codes, health and behavior codes primarily. We have not had, I don't know if I've ever had a patient say I got a bill from insurance. So we have not had trouble using H&B codes. You know, the downside to H&B codes is the reimbursement rate is very low.
Yeah. Mm-hmm. Dr. Ashby, do you use H&B codes even if there's a clear ICD-9 or 10 diagnosis for adjustment disorder or major depressive episode or bipolar disorder, psychotic?
Yeah, so we do for the in-clinic consultation because we conceptualize it as related to pregnancy, that it is worse because of pregnancy. It's an exacerbation caused by pregnancy. But if someone is going to come for therapy, then we use a mental health diagnosis, and that's their diagnosis going forward.
Mm-hmm. And if your first warm handoff is under 16 minutes, do you do incident to billing with the OBs or?
We haven't, I try to have people do 16 minutes. Mm-hmm. Because I also think it's hard to build a relationship in 5, right? And so like, let's stay for 16.
Yeah, that's what we would do. And I think incident to billing is a whole other conversation, but I wondered because I had never asked you. Thank you.
Yeah.
Mm-hmm. Other questions?
Sorry, I couldn't find my hand raised for a second. Jennifer, you spoke to utilizing and really operationalizing the PHQ-9 as your measurement for your measurement-based care. Forgive me, Bethany, I don't know, did you speak to the measurements that your Promise Clinic utilizes? And if so, could you just elaborate a little bit more on them?
Yeah, we use the EPDS. It's given at the new OB. Some of our practices do it in the 3rd trimester. It's also given prior to discharge and labor and delivery and at the 6-week postpartum visit. For patients that are coming for scheduled Promise appointments, we also do the GAD-7, we do ACEs, and that's all right now. And we do the MDQ for bipolar disorder also, if they're coming for scheduled visits. That's the new patient battery.
Thank you. I appreciate it.
Doctor, can you hear me? Apparently my volume's messed up. Dr. Ashby, and actually Dr. Thomas, if a patient is being seen by your service. Well, actually, Dr. Thomas, you're using the PHQ, so it'd be fine. Dr. Ashby, if you have a patient who promises seeing after pregnancy loss or termination in any trimester, do you still use the EPDS?
No.
And yeah, do you revert to another measure?
Yeah, we also try to be really careful for patients, really think with them about, because their appointments show up as in OB, they're continued to be listed as an obstetric patient. And so sometimes it's really painful. So we also really think with them about how is this going to be for you, even though you might like your therapist, but in this setting. So yeah. So we don't use it, and we try to think with them about if this is the right place.
Does everybody appreciate why I asked that question? Okay, just want to make sure, because some of the items on the EPDS are really difficult if you've had a pregnancy loss or a termination. Okay, thanks. Other questions? Issues you're struggling with implementation? Tried and hitting barriers?
I'm happy to jump in. So I'm coming from a very large university healthcare system that also recently just acquired an insurance company, a Medicaid insurance company. And we also just received word today that we're merging with another large healthcare system that's located north of us. I'm actually meeting tomorrow with our OB-GYN leadership because for this exact reason. One is the barriers to care. Two, it's just the overwhelming need. And so I think that we've identified our measurements of care. The difficulty is that right now we don't have staff. So we operate in a PCBH model to the best of our ability. We are young. We're roughly about 5 years old when I consider integrated care. And so we're actually creating, we're adding OB into our access schedule and hoping that will then develop. But really, we're looking at trying to implement it as best as we can while also still knowing that like our primary care team will be serving as also the OB care team for right now and how to like bridge those services. So this is very timely for us. This is certainly a struggle because for me as a clinician and as a leader, it's hard to say like, okay, like we're going to do this, but this isn't going to be enough. I know where this road is taking us and what does that leadership buy-in look like? Like not just buy-in. I think everyone is like, yes, integrated care. Yes, yes. And, but where's the support to say that this is at some point needs dedicated specific staff to move beyond because yes, we're generalists and that's the beauty of it, but there's also a specialist nature to a lot of this. And so I don't know if maybe, Helen, Jen, Bethany, if you have any recommendations, because I will be meeting with leadership to, like up even higher than me leadership to discuss this. So I don't know if you have any recommendations or thoughts. I've also proposed that our organization has looked into using 2 integrated models, which can happen. And I feel that like OB specifically perinatal and postpartum could be ideal for COCM. But again, there is that financial lift of getting psychiatry consultation. So I don't know if there's any recommendations, but I'm a case consult.
Yeah.
We're a
Yeah.
case consult.
I'm very familiar with your health system, so I'll because I do some consultation for it, so I'm happy to start. Yeah, and I would say this to almost everybody on the call. Start with the rationales, kind of a interactive rationale, almost a Venn diagram, if you will, from the maternal health perspective, from the fiscal perspective. You can make the case, show them the outcomes. But there's another outcome right now, which has to do with provider satisfaction, not just the patient outcomes, but provider satisfaction and retention. That is not an incidental issue to a health system. And in health systems with providers that are exceptionally overwhelmed, it is not incidental to have more satisfied, more supported providers. And we have good data, and Dr. Thomas and Dr. Ashby can jump in here, on the increased levels of work satisfaction when we have integrated care models. So I think what you do, especially for your system leadership, is show them the case in a very, very tight business plan. Executive summary with a couple of slides that drive home these, almost a TED Talk. Point A, point B, point C. They're driven by good care, of course. I love your providers and know them well. They're also, they also have a fiduciary responsibility to make a fiscally sound health system. And so show them the data very succinctly. They can ask for more detail, but you can make the case of what the impact is of increasing your integrated team on outcomes. So that's how I would approach it. If I was, serving as your consultant. I'll let Dr. Ashby and Dr. Thomas jump in here.
Yeah, so I would say I feel your pain and your aspiration of maybe like a blended model or both, because that's my pain point with COCM, is that my care manager gets full. I could fill up his caseload tomorrow. So I'm curious about PCBH type model. Like, oh, that's a nice, access in the moment. So I would encourage you to look at sites that are exemplars and blended models, because really the umbrella of integrated care, we shouldn't get, in the weeds of like one model versus the other. Everyone agrees that integration and working together is where it's at. It's just how we do it, how do we bill for it? Everyone should be pulling in the same direction. I know that Access Health, the FQ in Madison, Wisconsin, Dr. Zeidler Schreider's group is doing some really great work in blending COCM and PCBH. I know she's a big CFHA person, so I would encourage you to maybe reach out to her to kind of look through, like, what does that workflow look like if we're already doing PCBH style? We want to add a site consultant, do some COCM work. I think the combination of those two could be extremely helpful, and it's doable. People have done it. You got to be a good air traffic controller of who does what and when, but it's very possible. And I think that's probably the sweet spot, is to have that accessibility of PCBH. If they're crying now, come in the room, versus, oh, my care manager's full. What do I do now? I'm a PCP, so I think there's room for both.
Yeah, I would also add, I think in our discussions with leadership, it's been really helpful to say, with this amount of money, with this, whatever, this is what we can do. Yep. This is all we can do. We really want to do more, but this is our limit. So they're clear what they're paying for. And they're not somehow surprised that, like, why aren't you seeing every patient at their new OB? Why aren't you seeing every patient at their postpartum visit? That's like, we can do this, and we're going to do it really well. And that's what we're going to do.
Yeah. And I was going to say, Dr. Coons' point is huge with the provider satisfaction. That's one of the earliest things you'll see in your implementation. What things you can measure is put out a provider satisfaction survey, do a survey monkey. Your providers can show you that data, and someone smarter than me can quantify it. I think there's the stat of you lose 2 times that provider's annual take home and turnover costs if they leave. So the financial fiscal argument is there 100%. My other plug is your champions. If you can grow your own in-house provider champions for this work, that moves mountains, because they're going to be the person of the tribe, the culture of, they'll sit next to their provider. I don't know if we should be doing this psych work because I'm an OB and so are you. If you have a champion, mine is Mary Fitzgibbon. She was like, we can do this. And we have a great psych consultant. And it feels better to do something rather than just turn a blind eye to the behavioral health needs that are unmet. They'll inspire each other. They'll push the program forward and be your mouthpiece, your colleague, your ally, the leadership in those conversations. So look for allies. They're there. You want the same things.
Yes, and I want to underscore Dr. Thomas's point. You need an ally in that meeting as well, who can translate to both clinical and business and systems language. I don't have the citation for this, but there also was some incredibly powerful fiscal outcome data from Providence Health System on integration in the NICU. It was staggering data that truly had just monumental implications for cost of care when you had integrated services. And so I think when you start showing that, and of course, your health system has several, provides the continuum of care from both OB to specialty care and to NICU care. So some of that data, and it's certainly available, through excellent resources to really show that will be really helpful. We're just about out of time. We will make a PDF of these slides, none of which were meant to be comprehensive, but we hope that this community conversation has been useful. We're all available for consultation. We will also find out if you want sort of a deeper conversation about integration in other areas of women's health. We want to express our thanks to CFHA for your support of this program and your patience having to reschedule it. I think this might be the third attempt, so we finally got this started, and we wish everyone a safe and connected and well afternoon, and look forward to speaking with any of you offline if we can be of help. And you'll see our emails in probably the last slide in the PDF that that CFHA will make sure is posted someplace on the website. So in the spirit of the National Women's Health Week, may everyone both have a healthy and connected afternoon. Thank you, everybody. And if the speakers will stay on, and CFHA staff. Thanks.